got a lot to get through, so we might as well make a start. Got some administrative stuff to get through first. The meeting's being live streamed to the public. If there are any exempt private items on the agenda, the live stream will cease prior to the meeting moving into private, and there might be a short delay. A recording of the public part of the meeting will be available on the council's website within 24 hours of the meeting. Everyone's required to wear masks on entry and to the building and to the meeting room, but you, obviously, as you realise, you may remove them when seated. Okay, the microphones. If you haven't done this before, please remember to switch your microphone on when speaking. Speak directly into the microphone and switch off when you have finished speaking. I think that's important, isn't it? Because so that otherwise it confuses the live stream. Switch off mobile phones or put it into silent mode. Apologies. Sorry.
I was going to want to finish. Apologies. I wanted to say something, but once you finish, apologies, Chair.
Okay. Apologies for absence.
Apologies. We got apologies from Councillor Campbell, and Councillor Akbar is on his way. He's delayed. That's all, Chair.
Thank you. Minutes. There's two previous meetings that we have minutes for. Minutes for the 4th of May 2021. Presume everyone's had a chance to look at those. They're okay. And 18th of May 2021. Yeah. Okay, thank you. Does anyone have any disclosures of interest? Okay. There's no urgent business to report. Is that right, Bert?
None, Chair.
No references from committees or other bodies?
None, Chair.
Okay. Chair's update. I have nothing to report on any issues since the last meeting. Okay.
Chair, can I say something?
Please do, yes.
All right, okay. So I didn't have the opportunity last time after our meeting to say a big thank you to the committee. As the committee knows, I used to be the chair, and I would like to use the opportunity to say a big thank you for all your support during my tenure for the past 6 years. And I want to wish Councillor Underwood the best, and as you know, I'll always be here to support you when required. So thank you.
Thank you. Thank you, Councillor Ackley. And likewise, thank you for all your hard work over the past 6 years. Thank you. Okay, so if we move on to the first item on the agenda, update on COVID-19 in Luton. Sally?
Sorry. It's okay, I can talk. I just haven't got it on my screen yet, but that's fine. So the report is the usual format that Lucy was previously reporting in, and I've just updated it this morning with the most recent figures and update around our response. So as of today, our figures are 95 per 100,000 cases per week, which is, so a few days ago we were just above 100, so we've gone down a little bit, which is positive. But I think there's a recognition in the system that we need to be really vigilant still. We were above 100 only a few days ago, and obviously the position in Bedford in terms of how quickly they saw their case rates increase and the implications of the Delta variant and the increased transmissibility, we do need to be vigilant around that. So we are doing all we can to ensure that in schools, they're very vigilant about the messaging, social distancing still, and reinforcing the message about twice weekly testing. So we've just sent out a communication last week to all head teachers and all parents to remind them of this and to ensure that they're reporting results into the school as well as to test and trace, so that they can be followed up really promptly. And then if there is an outbreak, we can set up an incident management group and review actions and ensure everything's in place that needs to be. We most recently, it's updated in the report, but most recently we have made some changes to our plans around community testing. So the national testing strategy finishes on the 30th of June. So we've recently made a decision about what we need to do locally once that national protocols are finished. And we're all of the agreement that we don't want to stop doing community testing at this critical point. And the population community of Luton have really engaged with testing and really value testing themselves twice weekly, regularly, know where to go. So we've reviewed the locations and those that are more popular and where people are going. So we're continuing the mobile testing van in the square, in St George's Square. And then we'll be utilising the buses much more to go taking the tests out to the community and change the locations. And we'll have a clear comms plan around that. So we'll be able to promote where the bus will be at different times and different days of the week, with a sort of timetable spreading forwards in time so that people know where and when they can get tested. The Delta variant, initially, about 4 weeks ago, probably, thinking if that's the right timeline, we were being really proactive with any case that we were identifying that was the Delta variant or any other variants of concern. We were holding an incident management group looking at the case, looking at all the actions that have been completed, making sure that any public health actions have been followed up on. We're now seeing that that is the dominant variant in Luton. So we are just bringing that in as business as usual. So any outbreaks that are identified or any clusters, we're following up as we have been the whole way through. So looking at whether there's any additional public health actions that need to be in place, looking at whether all the contacts have been contacted, looking at whether the business, if it's a business, or school, if it's a school, has taken all the actions that they can do. So that's just part of business as usual now. And that's the case nationally, that variant is really increasing and being seen as the dominant variant and being brought in as just business as usual rather than increased actions. I think those are the main updates. I'm happy to take any questions.
Thank you, Chair. Thank you, Sally. In terms of symptoms, my understanding on page 2, I think, bullet point 9, talks about the continuous cough, high temperature, and the loss of sense of taste and smell. With the new variant or the Delta variant, apparently these are not the typical symptoms. So is there anything you're doing to educate the community or the population that, look, with those previous variant or the Kent one, these were the typical symptoms, but with the Delta variant or the Indian variant, the symptoms are completely different to this, and if we need to educate the community.
Yes, thank you. Yes, aware that the symptoms in the Delta variant have been at a wider range, so there are other ones that are under review as being part of the symptom list that are communicated. We haven't done any additional communications out about that as yet, waiting for national guidance and what the national team are doing about that, but we're keeping it under review. I'll take that forward this week and have a look at whether we need to be changing the messaging around that. Thank you.
Oh, yeah, there we go. Is there are you aware of any evidence that the Delta variant is causing increases in hospitalisation rates in Luton? Is that something you can a link you can make?
Yes, we're not aware that it is. In fact, it isn't at the moment. It will be kept under review, obviously. And actually, the evidence isn't showing that the Delta variant is any more severe in terms of the illness it causes, but that it is more transmissible. So that's why we need to be really vigilant. But obviously, if it's more transmissible and therefore greater numbers are becoming ill, then that would have a knock-on even without it being a more acute illness, that would create more people being ill. So we do need to be really careful. I don't know if, Nikki, if you have anything to add from NHS perspective.
No, other than the hospitalisation isn't an issue at the moment, but as Director of Public Health said, is that we're absolutely in close connectivity on that. So at the moment, no.
Thank you.
Follow-up question.
Yes.
In terms of people who are affected, I think the last report that came out was saying it mostly affected those who went to work, the working class, and people who live in highly concentrated areas. Is it still the same in Luton in terms of the Delta variant? Is it affecting the same people, or is it in the same communities? Or is there any trend to say it's changed and it's not affecting the same people, or the class of people it's affecting?
So throughout the pandemic, we have been seeing nationally and in Luton that the rates are highest in areas where people are having to go to work because of the nature of their jobs, where there's more dense housing or houses of multiple generation or multiple occupancy. So there are certain risk factors that make people more likely to acquire COVID just from their sort of day-to-day lives. And then that has translated into the sort of a cross-sectionality around certain ethnicities being more likely to be exposed to COVID. So that's been played out nationally and in Luton around certain ethnic groups. But it's a complicated picture related to all of those other areas that I've just talked about. So yes, we have seen certain geographical areas of Luton having more cases, and certain ethnic groups as well, and certain and groups that are more deprived. So there's lots of different ways in which you can look at the rates and who's more likely to have had COVID based on lots of different factors. So yes, we have been seeing that, and we're doing a quarterly report looking at those inequalities and disproportionalities that we can share as we do it quarterly.
Richard? You talked there about the Delta variant obviously being more transmissible, and obviously the speed we've seen it become the dominant variant in the country shows that. Do we have any numbers for how much more transmissible it is than the original novel coronavirus?
The evidence at the moment is showing it's about 40% more. And there's other variants that are coming in that are constantly being reviewed and under surveillance to get that picture. But at the moment, it's looking like it's about 40% more.
What about infection rates for younger people? Is that how it's spreading at the moment?
Yes. So the data a few weeks ago was looking much more like the increasing rates were in school-age children and sort of 18 to 20-year-olds. The evidence in the last week has shown that it's in all the younger age groups from 40 and below. So it's really looking like it is in those unvaccinated groups mainly, and those groups that are later on in the calling for vaccination. So we'll have lower rates, and in the working age population. So those groups that are either in school and mixing in school, or working and mixing and have those lower vaccination rates. That's what it's looking like, the picture is showing at the moment.
Could this cause us problems in, say, the next few weeks or months if it spreads from those?
It could, which is why we're trying to be really proactive with our approach. So we're looking at increasing vaccination uptake through promotion and additional clinics and options for people. So that's a really key factor in our approach to how we tackle this in Luton. So that's one area. We're also looking at if we need to bring in surge testing either in a small scale or in a large scale, then we will do that. But we don't want to do that unless we sorry, my microphone's a bit... unless we absolutely think that the benefit outweighs the additional resource and capacity needed to do that. But we are in regular meetings with the regional team about whether that's appropriate for us in Luton, and we could do that either in a small outbreak in a school or a workplace or at a wider scale, or in just one ward if we're seeing a big increase in a particular area. So there's lots of things that we can be doing to tackle this, but we've got a really good range of things that we're already doing and messaging that we're getting out there. And it's great that the vaccine is now available to 18 plus. So we are doing all we can at the moment and keeping it well under review.
Is it worth pointing out the vaccination policy at the moment that any adult can... Any adult, yes. It's just, as of late last week, been announced that any 18 or over can be vaccinated now. So, yes, really key message to get out there. Councillor Ackley?
Chair, in terms of schools, we mainly talked about secondary school. Have we seen any increase in primary school outbreaks, or what's the level, and do we need to take any action, or we need to communicate more? What do we need to do in terms of primary schools?
We have seen an increase when you look in the case rates by age group, in those age groups over the last few weeks. But we haven't seen a big increase in the size or number of outbreaks. So it's still sort of sporadic outbreaks or small numbers of cases here and there. So we haven't been seeing a large increase in big outbreaks in schools. Every time we have an outbreak, we hold an incident management team meeting and look at the actions and make sure that the teachers are briefed on what they should be doing and have followed all the right actions in terms of closing the bubbles and doing further testing, etc. But we have just sent out a letter to all of the parents and all of the schools around everything that they should be doing, reminding them of the bubble sizes, reminding them of the key messaging and cleaning and things. So we are constantly communicating with the schools. We have a weekly briefing with head teachers as well, and constantly remind them of the generic email address that they can contact in the public health team if they've got any concerns and if they've got any cases. So there's a really good communication flow between the public health team and the schools, which is working really well.
So in terms of that, do we know whether it's teacher transmission to pupils or it's people's transmission to teachers? Do we have the numbers that we can give? Or
we don't know that actually. So I don't have that information. The information isn't there. It's difficult to say where the source is. So I can't answer that, I'm afraid.
Does that mean our test and trace doesn't work anymore? Or because if that's the case, we should be able to identify whether the source is the people's or the source is the teachers, and how to deal with them.
Yeah, so in some circumstances, the first case that's identified will be the pupil, and then we do all the actions and follow up. That's the first case that's identified that has symptoms, and it may have come from asymptomatic transmission, or it may have come from home and come into the school. So it's very difficult to say exactly in that sort of school setting outbreak where the point source was, but we would know the first case that was identified to us and then follow up with further testing. So test and trace is working, but it's complicated, I think. But we do all we can in schools, and we have recently had an outbreak in a school, and we did follow-up testing across the whole school and identified just 2 more cases. So it wasn't a huge. There's not huge kind of whole school transmission that we're seeing in any of the settings at the moment, which is good.
And it is a standing item for every meeting.
Yeah. Okay, if we move on to item 8, COVID recovery plan. Nikki?
Hello, Chair. My name is Nikki Pullane. I'm the Director of Primary Care within the CCG. And this is a bit of a system report. Having just had a read of it before I came, I think probably one thing that is omitted is about the COVID vaccination programme, because that really is one of our major responses to COVID in the recovery. So at the moment, we're working incredibly closely with the Luton communications team and clearly with the public health team. So I would just like to emphasise that our concerted effort, because it is, the vaccines were open to everyone who's 18 and above. So that really does, I believe, help us in Luton, because we can certainly progress with families, because we know that the rates in Luton are less than the other places we have. So we have got some joint work with some outreach, which is really making sure that we are going into the populations where we know we're underserved. So with the support of public health, we know which wards are yet to have their first vaccines. So I'm not going to dwell, but it is an absolute, because you as councillors will make a massive difference about making sure that our communications is really working well. And last week I attended the Community Faith Leaders Group, so I'm just building on that. So that's one element that's perhaps not in the report. But if I just assume that people have read it, but I'll just work through. Clearly, we know that we have got considerable backlog. I mean, you'll have heard that through the television on the news, but this is actually giving you a real perspective of our Luton population. So it's an absolute concerted effort. So just making sure that people are aware that of course there are other priorities other than these 6, but the 6 that are cited, and I'm going to go through because I think it is quite important. So very much supporting the health and well-being of the staff, and that's health and care staff, because again we recognise that many staff have been working tirelessly at this, and that's across the board, and equally recognising that we've benefited immensely from volunteers and retired staff who've come back into the workforce. So there's a big effort about retaining staff, because there are a lot of people who are exhausted. So it's about us really making sure that we're there to support them. So emphasising that first one. I've mentioned about the COVID vaccination programme. That is something that we're working with the national team, the regional team, and us as the clinical commissioning groups. As you're aware, there was a finite amount of vaccines, hence the reason why it's been so regimented about age groups. I can give members confirmation that there's sufficient vaccines for those that are under the age of 40 with the Pfizer and those with AstraZeneca. So at the moment, and this is real-time information, we have more available slots, and that's bookable and walk-ins. So if we can have a bit of a discussion about how we can collectively, again, make sure that message is going across, because I know the numbers in Luton, that there are people that need the vaccine, or we need to encourage people to have the vaccine. So it's interesting that I've got 2 colleagues from East London Foundation Trust. They've been working really hard as an organisation to help us to reach our population with serious mental illness, because we know that on a national level, often they're underserved, and we have to make sure we take the vaccine to them and not assume that they will be proactive and come to us. In the same way as the homelessness, we've worked really well with Sally, with Sally's team. Make sure I got the right name there. To make sure we're really homing in and focusing, and equally I think we've done quite well with the Gypsy Roman travellers, but again there is a continual work in that front. The other next step is the restoration of elective and cancer work, because clearly that is a concern, and that has an impact on mental health when people are in pain, if they're waiting for operations, and equally into primary care, particularly with GP practices where people you know, are wanting some reassurance and probably some airtime because it is distressing for those people waiting. Now, further on in the paper, it mentions that we as a system have been fortunate enough to be accepted as what we call, sorry, the NHS has lots of acronyms, an accelerator programme. And that means that we've got some additional funding that's come into the Bedfordshire Luton Milton Keynes to help work through that backlog. So that really is of my colleagues in the mental health trusts and the acute trust and the community trust, and that really is working it through. So that's one of the other priorities. And we've got a paper later on about expanding primary care capacity. And that is more than general practice. That is primary care capacity. And we'll talk about that a little bit later on in a bit more depth. But we know that many people have held back, who have long-term conditions, or who may not have come forward with their screening. That may be, you know, breast screening, cervical screening, all sorts of other screening available, and equally with other immunisations. So one of our absolute priorities with our public health colleagues was children, because the last thing we want is an epidemic of mumps, measles, or anything on that. So there's a lot of backlog of primary care. And another of the priorities, and that came through, if everyone remembers, the long-term plan. It feels a long time ago, but in January 2019, and that was very much responding to community urgent care. And I think we've seen it at this scrutiny committee, is about the ageing well, and that is very much about at a place level, making sure that we have a responsive, and it is a 2-hour wait for community responsiveness, and equally on the rehabilitation, reablement, there's some measures there. So again, big priority. And then the last one, goes without saying, is working collaboratively across the system. And I think for the one benefit that has come out with our pandemic is how well health and social care and voluntary and community sector have all pulled together. You know, I think that will speak for itself. So those are those priorities. Now, it's just to give the committee that assurance that this is monitored very closely by the regional teams. And again, that is not just about monitoring, it's about where we're learning best practice. So we're not in isolation of Bedfordshire, Luton, Milton Keynes. So there have been a number, we put in there the narrative plan, the activity performance plan, workforce plan, and in particular the mental health workforce submission. So you'll notice later on in the paper, it is quite eye-watering, and my colleagues on the right, where we've got a recruitment of 500 staff, and that's absolutely in the mental health. So it demonstrates where we've got the priority, but equally, I think it is fair to say it is quite a tall order. So we're having to be quite innovative of our service models and the workforce supporting that cohort. In the paper, it mentions about the self-assessment, and that's important, and that the self-assessment is shared with the Chief Execs Forum to make sure that we've really got a rigorous self-assessment, and self-reflection is really important, because it's how organisations can reflect with each other. So in particular, it's about making sure that we're really, I would say, honest, and recognise where we are and where we need help. And that's where the regional and the national teams come, if our self-assessment in some areas shows that we need help, and that's the focus area there. And then it equally just discusses the governance and reporting, which is really, again, important. One, to get that right so that we're working smartly, but secondly, if we've got any shortfalls in any of those 6 priority areas, is that we are able to take action quickly. So that's an overview of the paper. It's probably worth questions, and I may utilise people in the room, because, as I say, this is very much a systems paper. It's not something just in standalone of the CCG.
Thank you. Any questions?
And then it's to do with page 15, cancer, 62-day plus wait and backlog. I know you said it's a system question, and in terms of place, when we talked the last time, Luton as a place we know we have issues with in terms of cancer and diagnosis. And have we made any, I know because of the pandemic, things have stalled a bit, but have we made any progress saying there's a backlog? If there's a backlog, what is the plan to catch up? And do you have any timelines in mind?
So thank you, Councillor. There is a very rigorous cancer plan that the acute colleagues are holding the ring on. And you're absolutely right. So in Luton, we've had our performance where we know that patients tend to present later and often in an emergency setting. So that has become an issue across wider systems. So my expectation, and we've discussed this within the systems, it's probably made worse in areas where they weren't coming forward earlier. So a very, very focused work that's clinically led. We have Dr. James Ramsey, who is the cancer clinical lead for our system, and that absolutely looks at variation at practice levels. So that may be of the GP referrals for those coming forward for 2-week waits, all the way through to people who have then been referred, and then that's a process issue, all the way through until, as you say, it says in the report here, of actually commencing treatments. So if you would like something more detailed on the cancer, that can certainly be arranged, but that's a very, well, one of the 6 priorities, but yeah, that's being very closely looked at.
For staff workforce, I know the long-term plan was GPs to recruit to certain level. Do we know if that's happening? Because without the workforce, it's going to be difficult to achieve these targets. So what are we doing in terms of the workforce, bringing them back? Is there any plans? And more, as somebody who works in the NHS, I know how it's like everybody's tired, and the government is saying it's not going to give us any pay rise, but 1% is not helping. So what is the plan in terms of workforce in the system to be able to do the work that is required?
So within the ICS, there is something called the People's Board, and that's called that the sort of hub. But being the Director of Primary Care, I'm quite cited on the primary care workforce. So our GP numbers are fairly flat, so which is better in the fact we haven't lost any, and we have gained. I can get those data for you, but it isn't to the levels we needed. If you remember that workforce in primary care, we something called additional role reimbursals, ARRS. So we will have I'll have to clarify the numbers, but it is something like 195 from memory, something in that ballpark figure. But there's a whole range, it's multi-professional. So this year we have, for example, nurse associates, we had physician's assistants, mental health practitioners, community pharmacists. So I think we're up to 15 different roles, and that's recruited on a very processed page, in that each of the primary care networks will look at their needs of the population. They will look at the gaps. So it is done with some tools that are provided through our Health Education England and with our workforce colleagues. So it is quite a specialist piece of work. So those numbers, so we've increased capacity in the primary care networks. So that's supporting care outside hospital, not just general practice. It's looking at improving the health of your population in Luton. Yep.
Mean to transform the reporting and clinical behaviour? Oh, sorry. point 12, it's the section on the cancer and the 62 plus weights backlog.
Yep. So from this report, I'll make an attempt, but having heard the clinical leaders in this area, we're reliant on general practice referring the right patients through on the 2-week pathway, so that 2-week wait. We do know that where there is a longer waiting list, so if I was a GP and I thought you would get, I wasn't that worried about cancer, but I wanted it confirmed and I knew you'd be seen in the normal way within 6 weeks, I might not put you through the 2-week wait. But as we're aware that the waits are longer with the backlog for COVID, and you may not be seen for perhaps 10, 12, could be 20 weeks, that a lot of our clinicians are using the 2-week wait pathway more than they would normally. And that's just so that patients don't have a longer wait to exclude cancer. So I'll just make sure you really are clear. So so sometimes GPs will think, goodness, I really think this is a high risk of cancer. That's where they would normally use the 2-week wait. If I was a GP and I thought, I really don't think it is, but I want to have a second opinion, they wouldn't use the 2-week wait. So at the moment, that's what that sentence meant about clinical behaviour. Yeah. And I apologise because it's only because I was in those conversations I'll be able to translate that. Yeah, that is, and I think it's really important just to be objective. That's not saying that a GP's behaving inappropriately, is that they need to be for their clinical assurance, and ultimately it's their professional integrity, is that if they feel that they want somebody seen within 6-7 weeks, it at the moment it is not inappropriate for a GP to use the 2-week wait. And I know that the cancer leads are now, when they're doing referrals, they're stating to exclude cancer versus to confirm. And that actually just helps the clinicians do some of that prioritisation. So that if a GP really is so concerned, they haven't called it 2-week plus, but it's just trying to make sure that they're helping secondary care clinicians to prioritise. Yeah. I have got the next item, and that's the ICS update. So I'm assuming everyone's absolutely aware of the integrated care system. So in fairness, I could probably give it to any colleague to do because we're all members of the ICS. And I think the committee asked for an update. So on the first slide, it mentions strategic priorities. And I wouldn't be surprised if any of you were at the workshops. There were 2 considerable workshops that took place, but I know there were a number of task and finish groups. So this was very much about agreeing as a system what the strategic priorities were. And again, really emphasising it is based on population health outcomes and most importantly about the inequalities that we know have been an issue with pandemic. Just making sure that people are aware that the long-term plan that was published, I mentioned earlier, I think it was January 2019, remains our, you could argue, agenda. So the priorities in the plan remain. Clearly the challenges of COVID and, as I mentioned earlier, some of that learning, the opportunities. So as an example, the digital agenda that was in the long-term plan has been accelerated considerably. So it's very familiar now of patients having outpatient follow-ups, for example, as a consultation remotely. And it's very much the priorities. It's about the single system. So, for example, using data, using areas where you would want to be at scale. But the important thing on the ICS priorities is place is sacrosanct. So we have 4 places, and I know that I think Rima came to, I'm not sure if it was the Scrutiny meeting or the Health and Wellbeing Board, but absolutely said the importance of place, which I know is important to yourselves. And it's that wider co-production with, and I know there's colleagues here from Health Watch, so I'd hope they would recognise that co-production with our communities. So the next slide talks you through the 5 priorities. Having worked with Luton for a long time, the first 3 I think mirror what were in Luton's health and wellbeing. So the very first is giving every child that strong, healthy start in life, the first 1,000 days. Very mindful in Luton, and I think it's just under, it was 46%, it may well have gone up with the pandemic, of children in receipt of school meals. So we know that we have a real issue on poverty in children. So a big priority in Luton, equally a very, very young population. Second one, very much supporting to engage with and manage their health and well-being. And then with total well-being, Luton, very much with the stop smoking, with the weight, early access to the IAPT, improving your psychological. So all of that very, very important. And then the people aging well with proactive interventions to stay healthy, independent as long as possible. And Luton have very much led the way with the interprofessional working with the mental health community, local authority and the CCG with regards to managing frailty and that proactive home, primary care home model. And then the 4th, working together to build the economy and support sustainable growth. Again, mirrors in with your Luton 2040 priority and policy. And I know that members of your chief exec and your leader of the council have been very instrumental in that. And then in everything we do to promote the equalities in health and well-being. And in fact, it's the chief exec of East London Foundation Trust that are leading that work, which is about really addressing the inequalities. And there's work not only at a BLMK level, but equally across the systems, because there's a lot of learning across the systems. And then the boxes at the bottom are all the enablers. So digital and data, workforce, ways of working, estates, communications, finance, and the operational and clinical excellence. And there are considerable work plans underneath those, but they are the enablers. And then if I move you to the next slide, it is the slide that just shows the role of place. And I think it's fairly self-explanatory, but it does explain the importance of one-to-one clinicians with patients, and then with the primary care networks working at a neighbourhood level, and then working at this place level, and then working where it makes sense to collaborate. So at the moment we're working with the Bedfordshire Care Alliance, and then the layer above that is what's meaningful to work at scale at a system level. And then I'll take you to the last. So I mentioned that there were a couple of workshops. These were reported to the last Luton Health and Wellbeing Board that it was signed up to. And very much what we're doing today about embedding it across all areas of the place of Luton. So, and then the very, very final, you may be aware that the Health and Care White Paper was published last year, and it was in the autumn, and where are we? I think it was last Thursday, it was published what the proposal, further guidance through the NHS, and I believe that the local authorities have been having some briefings because the white paper is systems. It's not health, it's actually how the systems, including the local authorities, are going to work. And I think that's what Rima, the chair, and Felicity Cox, the executive lead for both the CCG and the executive lead for the ICS, has mentioned, and yourselves are all part of that at the moment, the partnership board. So with regards to the health and social care integration bill, that's all subject to it working its way through, that you're probably as more familiar than I am of how it works its way through Parliament. So from April 22, there is going to be, we anticipate, an ICS within it that will be accountable for the outcomes of the health of the population. There will be an ICS NHS body, according to the latest guidance, as I say, subject to all of it working its way through legislation, that will be responsible for the day-to-day running, and there will be an ICS health and care partnership, which brings together all of the systems. So a lot of, I would say, a lot of water to go under the bridge between what that will look like. Within the guidance, there's quite a bit, I think, of local flexibility, so it will be how system leaders work that through in our BLMK. There will be establishing effective ICS, which enables care alliances, and I think those are yet to be defined, really, and places and the PCNs to flourish. Again, I think the important thing is neighbourhoods are really important and places are really important. And as you're aware, there's already forums in place that I know many people in this room are part of. So that's just the update from the ICS. Again, happy to take questions with colleagues.
And I think one or two. We've reported about the footprint, and now there's going to be boundary changes. Is that going to affect how we are going to operate? Because if that's the case, and some are going to go into other footprints, how are we going to work that one? Has anybody looked into that? That's the first question. The second question is, we as a group, in terms of health scrutiny, we used to be part of the JHOSC, and what we're thinking about the HOSC, whether it's going to work and how we're going to be involved. I'm not too clear whether that has been resolved.
So if I take the first question, and welcome others' contribution, is that I think if we're using populations and the outcomes of the well-being for our populations, boundaries need to be gone. It's how we work for the benefit of the patient and the population we're serving. I believe, reading in the papers, is that the units of primary care networks are quite strong. So that is populations through GP list sizes. And as you're aware, in Luton, we've got 5 primary care networks. So already we have providers aligned to those PCNs where they have unique needs for their population of that neighbourhood. And I know that the 5 primary care networks work collaboratively to unmet needs that are place wide. So just as an example, the primary care networks will have accountability to improve and address some of the inequalities to their neighbourhood. So that's likely to be some unique, because it's about making a difference to individuals. So in answer to your question about the boundaries, I'm not aware there's been any change in boundaries. I think for all organisations, healthcare, community, local, voluntary sector, the boundaries have to go when you're looking at a population, and that's where the population health management, I think, really is a golden thread through some of those. I'm not aware of the boundary issues. Was it boundary issues of organisations or?
About how that is going to affect patient care in terms of when you have these boundary changes. So I thought maybe somebody would be familiar about the latest update in terms of the warning from the NHS providers saying, look, we think there's going to be an issue and patient care is going to be affected?
So I can briefly answer that question. So there are some proposed boundary changes in other bits of the country. They don't affect Bedfordshire, Luton, Milton Keynes. It's largely to bring ICSs to be aligned with local authority footprints, which is not an issue for us here. There are some in east of England, Herts, West Essex, but not for us.
That's lovely. And so please remind me of your second question. So I have skim-read, not in depth, but the Health Overview and Scrutiny Committees are mentioned, and equally the Health and Wellbeing Boards. I think, again, with other colleagues, I think a lot of this is to be determined, but I think the role of Health Overview and Scrutiny Committee is there, and it's how, particularly I think working with the 4 Health Overview Scrutiny Committees in the BLMK system is how you will help to develop it. My understanding is that you will be, your input will be, if it's not already, sought for that purpose.
Yes, that's good to know that our input will be sought. I think there are plans afoot to try and get the this committee and the Health and Wellbeing Board and the other relevant committees to work more closely together. So hopefully in the future we can put that into practice. Any other questions from anyone? No. Thank you, Nikki. I think you're taking the next item as well.
I am, but this is the last. So primary care access and GP access. And GP access and primary care access are hand in glove, but they are different. And I think it's really important, and I know those that have heard me before, I mention it all the time. Access to GP practices are part of primary care. And I think certainly through the COVID vaccination, for example, the community pharmacy have really come to the fore, and they have added capacity. Perhaps not so much in Luton, they have added capacity, but in central Bedfordshire, where we had quite a gap of GP practices coming forward to do COVID vaccination, is that the community pharmacy model has really helped. So I just want to make those 2 elements really clear. So I'm going to start first of all with GP practice because I know it's close to your hearts, and then I will just mention about the wider primary care. So as far as GP practices go, and if I just take you through the paper, one of the first elements with our 5 primary care networks, and we also have Dr. Nina Pearson, who is the Clinical Director of Transformation that supports Luton, is about making sure that primary care is accessible. I'm sure many of you are aware through the media that there has been a little bit of a breakdown on a national level with GPs because I can confirm every GP practice in Luton is providing face-to-face consultations where clinically indicated and needed. And I think it was a little bit of a blunt instrument, that's 2 or 3 weeks ago now, where the suggestion was that GP practices weren't opening the doors. I think it's, again, very important, particularly as Sally has mentioned about the infection rates, that we cannot be complacent. So our practices, and that's not just GPs, that's the practice managers and their wider teams, are working very, very hard to address patients' needs, and where they can, remotely. We're absolutely mindful, and I've got somebody in the team working very close about those that haven't got access to, we talk about digital, so that we are not excluding those people. And I can assure you that the local GPs are very, very mindful on that. At this moment in time, there is definitely a backlog, as I mentioned, and as that's one of the 6 priorities I said about the reset. And we know that and we work with Health Watch, so we know that that is a concern about people's expectations. I think for me, that's one of the reasons why we've worked very hard at, when I say about primary care, so about utilising. So for example, if a patient wants to access some services, it is possible that you could get that service through the community pharmacy. But we, and I do stress, we have got to work hard with the local population to make sure that that offer is seen as an alternative and not a second best, and more to the point that they can understand how to access it. So I have in the team, we've pulled together what is called a primary care access group. So I have just in the paper outlined, and as you'll see, that we've got other colleagues that have joined that access group, particularly we say about, in fact, it happens to be Luton's Health Watch that's on that meeting. Because, for example, the 2 areas we've identified in Luton where there's quite a high demand, and that is for children. So it's how we work with children's team and mental health. So often there are patients needing more urgent mental health requirements. So if we get that model of care right, they shouldn't have to be a blockage of going through to the GP. There should be a direct access into a mental health urgent service. So that has been working particularly with our mental health colleagues about getting those pathways right. And it's all about communication to the GP, so they're aware of what service is available. And equally, the more self-referral we can do for patients. And often it is patients known to the system. So we are very much helping to signpost patients, and we don't like this attitude of discharging patients, so that if patients have a reoccurrence of an issue, that they know how to access the service and not always coming back through having to get a GP appointment. And that goes back to our model of primary care home. So that again, I think the paper explains that it's not as straightforward. I think the other point to raise is that the demand in general practice has gone up phenomenally. So if I just, that's general practice, but if I can just mention on the wider primary care, and I'm very happy to go back to particularly GP practices, is remember that GP practices are in theory open at 8 in the morning and they close at 6:30 at night. Many have extended hours, and many work some sessions Saturday and Sunday, but we are reliant on our 111 if you need out of hours. So the 111 service has had almost a double of demand. So the numbers have almost doubled. And as you'll remember, that one of our quality metrics is that the 111 is answered within 60 seconds. So it goes without saying that if you have more calls, double the amount, we have failed on some of those targets. That's poor, because if you're a patient using the service, the fact that you might have to wait up to 2 minutes at the moment, and we're really working hard with the provider. So as you can imagine, we have anticipated where those, the times of the day where the figures are higher. And interestingly, it's in hours. So the out of hours period, we're answering the phone in reasonable time, but it's the in hours. And we are, in the paper, it mentions doing a campaign, and that is very much with all of us. So for example, if you don't have an urgent need, then it's better not to ring the GP practices in the morning. between, say, 9 and 11. So if you are wanting to phone up for a result and there's no urgency, encouraging people to phone in the afternoon, and it just helps to spread the demand onto general practice. Equally, so that's the 111 service, and equally, again, working with, because I mentioned it's children's services and the mental health services, how we really facilitate that access into the primary care. Yeah, I just wanted to mention that our attention to those that haven't got digital access. It isn't the paper really emphasises it's an ongoing work, and there isn't a quick fix to this, other than there is an absolute commitment from all. And for me, it's emphasising that system working. And to the committee, it is very much about the communications campaign. So I'll probably stop there and take some questions.
Good to hear that GPs are still able to see people face to face, but the information coming back or some of the groups is very difficult. And it's like GPs are reluctant to see people face to face. They're resorting to maybe the telephone triaging, or there's what we call people in the front face as blockers. How do we monitor this? Because if cases are urgent, and as we talked previously, we leave it or people are discouraged, they present to any A&E or at a later stages when the situation is irreversible. So what was the plan to make sure that GPs, yes, they are opened, but they are saying a greater number and slowly hitting the upper level than the bottom level to say, okay, we open, but we see maybe 10%. Maybe you should be seeing up to 90%. How is that being monitored?
I appreciate that question, because as of the 30th of June, we will have our first data set and that's through the benefit of the national team, where we'll be able to see the activity of GP appointments. So that's a segment of the wider issue, but it helps me to see if there's any variation. So of our member practices, if we had, for example, some variation, we need to understand that variation. The variation, if it can be quantified and understood, that's fine. But it would be very strange if you had very, very few face-to-face in one practice that was quite at odds to another. I think so that is how we can monitor and have those informed discussions. I think the point that I probably failed to mention earlier is there is a large amount of work with the general practices, and that's really through the primary care networks of working collaboratively with the care homes, so that particularly the older people's care homes. So that's more efficient and less footfall going through to a home. I will emphasise that all of the staff do very extensive testing, COVID testing before going into a care home, and that's something which, working with the public health teams, we've been really vigilant on, because again, protecting. So that's monitoring. So we are monitoring face-to-face consultations, telephones, and into care homes, so the variety. Equally, it needs to be mapped on our 111, because do you remember that in the 111 service we have directly bookable appointments? So, and I always stress this sentence, that if you have an urgent same-day need and you can't get through to your GP practice, we encourage people to ring the 111. It isn't a way of getting an appointment, but if you are clinically indicated that you need an appointment, there is the opportunity to have it directly bookable. So I always say that, I wouldn't want anyone saying that you book an appointment via 111, that is not it. But if it's clinically indicated, they will find you an appointment for that day. It's what we call same-day urgent care, and that mitigates the risk of people attending A&E, which would be quite wrong, because that, again, risks bringing infection into the A&E department if it can be managed in a primary care setting. So that's all being tracked.
I had an experience, somebody was telling me that they called 111 when they were told, call X surgery and you should be able to have the appointment. But when they called, there was that barrier telling you, have you called this? We don't know you're coming. How are they going to deal with that? Because they were told specifically, call the GP, there's some space for you, and they're facing barriers as to how to go through the GP system.
If there's any of those cases, if you escalate to me, we can work them through, because that shouldn't happen. It's a directly bookable, and there may be some, some individual issues there. So very, very, very happy. I'll probably use the generic email that I can give Bert, so that if anyone has those issues, I can put it straight through to my urgent care team, and then we'll pick that up. And it's a lady's name called Barbara Moran. Yeah.
Our population, I know we are moving really fast, or the system is moving, but they're not aware that things are changing. How are we educating the population that, look, things are changing. What we used to know before that, you just get up, call GP, and you're making an appointment, and you don't have to rush the A&E. It's education materials going out. I haven't seen any in a long time, so I want to know, are we doing that? Because if the population don't know what we're doing or how things are changing, they still have the old system in mind, and that's what they're going to follow. So is there any education in terms of that, how we're changing our systems?
Yes, within the ICS team, we are working on what we call our access campaign, and exactly that. And I'm not sure if anyone, I think Health Watch have been working with the comms team. I don't know if anyone has any experience of that in the last, no. So very, very happy to bring that or to do it outside the meeting to yourself. So it is being led by our Director of Communications, Jay Meggett, and we're calling it our Access Campaign and into primary care.
Thank you. Yeah, I think that's an important point, isn't it? Trying to identify where the problem is. If it's just something as simple as people don't realise that that's the process to follow. Could I just get something clear? If you're using the 111 service and the person on the line says you can have bookable appointments the following day, then that should be passed to the appropriate GP surgery, and they should know that that person can have an appointment the following day. So that's correct, isn't it?
Yes, so the 111 service, if the person's clinically in need of same-day care, they can either have a directly bookable appointment. The GP practice have to release appointments to the 111 service, so that's one option. Or we have something called extended access. So we've got a second place where it may not be your own GP practice, but the patient will be offered that, and they'd have that explained to them. Yep.
Thank you. Any more questions?
And because what you said, I think my wife had the same experience. She had the surgery, and I think he was still bleeding and wanted to call the GP, and he was referred to some other center, and she wasn't sure why he didn't have access to her own GP, but he went to this other site, and it did work fine, so that did work, to be honest.
Thank you. Item 11, update on modernising inpatient mental health services in Bedfordshire and Luton. Is that better? Can you hear me? Okay, great. So just to preface the presentation, just to note that we are not proposing to reduce the number of beds available to Luton residents through this set of proposals, and that we are, in fact, keen to assure the committee that we will be ensuring through these proposals in the future that all of the 600 residents that we have on average a year admitted to an acute adult inpatient bed will be admitted to our Luton Centre for Mental Health. So just wanting to kind of give the committee the assurance at the outset that that is the case in these proposals. The proposals also enable us to make an offer to children and young people locally, currently all of whom are admitted to placements which are out of the area, so out of Bedfordshire, Luton and Milton Keynes, because we don't have a facility for children and young people at the moment. In the future, we're proposing to admit them to the newly built development at the Bedford Centre for Mental Health. What we're presenting tonight is our draft case for change. The committee may recall that we attended in January where we made a commitment to bring back our draft case for change for your comment and view. I do want to emphasise that it is draft. We're currently working on the final version, which we expect to have developed over the next 2 to 3 weeks. Our intention is to publish the case for change in early July and to, over the summer, carry out a process of engagement. And you'll see attached to the case for change is also our very high-level engagement plan. So we want to have as many conversations as we possibly can about this document with service users and carers, with local residents, with key stakeholders such as yourselves, in order to test the proposals and help us to refine them further such that we are able to work towards the kind of full business case document, the pre-consultation business case, which we have to bring back to you for consideration before we potentially then move to formal public consultation. You'll recall when we came in January, and similarly to the other 2 council scrutiny committees whom these proposals affects, you were clear with us that you believe our proposals to constitute significant change that would warrant public consultation, as did the other scrutiny committees of Central Bedfordshire and Bedford councils. So I'm not going to talk through the case for change in detail, other than just to note that it attempts comparatively briefly to do 3 things. The first is to lay out the strategic context for these proposals. The second is to lay out the proposals themselves. And the third is effectively to lay out the rationale for the proposal. So why do we believe that these sets of proposals is the right thing to do to meet the needs of the populations of Luton, Central Bedfordshire and Bedford Borough. And you'll see that towards the latter bit of the document, you'll see that we've laid out our case for change against 5 domains, and we have included against those 5 domains a number of quotes from service users, carers and our staff, which are direct quotes that we've gathered through our engagement with staff, service users and carers to date. And I think that hopefully you will see and agree that they lay out really quite a powerful case for change, orientated around the need for us to improve the quality of the environment. In particular, you'll see that we lay out a case for change around psychiatric intensive care unit for care for men, where we believe we need to make considerable improvement to our current environment in order for it to be able to provide safe and effective care for men who are amongst the most unwell in all of our services. The fragmented nature of our services, you'll note that we currently provide inpatient services across 4 sites in Bedfordshire and Luton. So older adults currently admitted, if you live north of Central Bedfordshire and Bedford, to Fountains Court at Bedford Health Village. If you live in Luton, you can be admitted to Oakley Court, to Townsend Court, or to the Luton Centre for Mental Health. And on average over the last 3 years, around about 10% of
residents have been admitted to our London wards. So that is quite a fragmented setup, and we have these 2 isolated wards at Townsend Court and Oakley Court, 2 wards each, 3 acute adult wards, 1 older adult ward. Our proposal is, as I say, to relocate those wards to the Bedford Centre for Mental Health, to relocate the older adults ward to the Luton Centre for Mental Health, and for all Luton residents to be admitted to the Luton Centre for Mental Health in the future, which will also mean that we will no longer need to admit any residents to our London wards going forward. So the fragmented nature of services. Local inpatient services, clearly we made a commitment when we moved our Bedford inpatient services from Wellowing in 2017. We made a commitment to the residents of Bedford that we would return inpatient services to Bedford. Our set of proposals allow us to do that. And capacity in the right place. So you'll also note that we, through these proposals, are intending to increase the number of acute adult beds by 6 beds, to increase the number of male psychiatric intensive care unit beds by 2 beds, and to increase the children and young people's beds from 0, as it currently stands, to 18. Now, I hasten to add that that is our current view of what the bed capacity will be. We are currently testing that through a piece of work which is quite detailed and specific, looking at demand and capacity in the context of population change over the next 20-25 years. We clearly want to make sure that we're not just building something for tomorrow, that we're building something that's fit for the future in terms of how the population is likely to change. You'll note in particular from the report that that there is significant growth in people aged over 65 over the next 20 years, and in particular we're thinking about our older adults, inpatient to community services, and how we best meet people's needs in that context. And then finally, the fifth element, the fifth argument we've laid down in the case for change is using this as an opportunity to really think about our whole system, our whole approach to care across inpatients and community services. You'll note from the case for change that the integrated care system across Bedfordshire, Luton, Milton Keynes is investing significant amounts of money into community mental health services through to 23-24, which gives us a really excellent opportunity to think through how we design care pathways which keep people at home, prevent them from becoming unwell, and support people to flourish, really, in their communities. Just finally, to note that we estimate that the costs of the new hospital at Bedford Health Village are in the region of £60 million. We have, we're also working, as I say, on our plans for reconfiguring and refurbishing the site at the Luton Centre for Mental Health. At the moment, we estimate those costs to be in the region of £10 million, but I do want to note that that's preliminary. £70 million in total, which the Trust is committed to investing alongside all of the new investment going into community services. It is a significant investment by both the system and the Trust into mental health services over the next 2 to 3 years, both in revenue and in capital terms. It's important to note that we are working through with NHS England and NHS Improvement, our regulators, the capital cover, the capital departmental expenditure limit cover that we need to have in place in order to be able to move into formal public consultation as part of the NHS's process for assuring change. So we're working through that at present. On that note, I'm going to pause and hand over to Dr. Manns.
Thanks, Richard. I'm not sure I have a huge amount to add, really. Just perhaps, though, I would emphasise, as I think I did last time when I presented to the committee, just how excited we are as a provider to be in this position of developing a brand new unit in Bedford and substantially upgrading the Luton Centre for Mental Health. at a time when there's unparalleled investment in our community mental health offer and crisis offer also. So I think if we fast forward 2 or 3 years, really the offer to residents of Luton and other parts of Bedfordshire is going to be radically different and much improved.
Thank you. So, anyone have any questions?
Why should I travel very far to go and do this when I used to have a perfectly one that I don't think had anything wrong? That's my observation.
Providing inpatient services across those 4 sites, 5 if you include London. Our proposals are to move to a 2-site option, where if you live in Bedford or the north of central Bedfordshire, you would be admitted to the Bedford Centre for Mental Health. If you need an acute adult admission, which is by far the largest amount of inpatient services that we provide. But if you live in Luton or if you live in the south of central Bedfordshire, you would be admitted to the Luton Centre for Mental Health. And building that new ward, that new hospital in Bedford, and significantly improving the quality of the environment and reconfiguring the quality of the environment at the Luton Centre for Mental Health is very much part of the plans.
Actually, this is local to my the Convent Court. That's you're going to close. It's not only my patch, but also it's a very local, and the people who are will be very concerned about that. And this service was opened not long ago, and why that is going to close again? I know I think it's 2001 or 2002. That was newly built building was actually initiated by the department, and the hospital. I'm not too sure what services you're going to provide, and whether you will be accommodating the local people adequately. So, I will be personally, and the people will generally be actually upset about that. Okay.
Sorry, is that better? So we are going to put the exact numbers in the case for change, but Oakley Court at the moment predominantly serves residents of Bedford and central Bedfordshire. So it's very much featured since the closure of our unit in Bedford as the ward to which we've admitted people from those areas. And of course, in building the new unit at Bedford Health Village, they will want to be admitted there in the future. So that's the kind of reason for why we're proposing to close Oakley Court. We are, as part of the proposals, beginning to think through with partners about what we do with the sites when they close, but we don't have any firm plans yet. That's certainly something which is on the agenda for us to think through. with you, with colleagues in the council and colleagues in other organisations locally to think how we can make the best use of those sites in the future.
Yes, please.
Thank you, Councillor. I suppose I had a couple of thoughts about Oakley Court, if I may. So I think Oakley Court, similarly to Townsend Court, they're not very old buildings. We've certainly worked out of some older buildings in the past, but ideas about design change over time. And what our patients, what our service users and carers are telling us about these, the wards, so like the Oakley Court wards, for example, is that they're not welcoming, they feel institutional, they're not pleasant places to be, they give the wrong message from the point of arriving for a patient. So they're challenging places to be. Our staff do a brilliant job of working out of these services, but they're not really set up for delivering modern adult mental health inpatient care in the way that we would want to. The location of Oakley Court in the middle of residential area, housing estate, is really challenging in terms of the setup as a community-facing inpatient unit, so it's difficult to think about therapeutic leave from the ward to arrange time off the ward for people unless someone's collecting them or taking them some distance from the ward. And I think it would be fair to say that we've done a lot of work with local residents around Oakley Court to mitigate some of the challenges inherent in having a inpatient unit in the middle of a housing estate. So the kind of noise and disruption that can go along with an inpatient unit which is located in such a place. So I think certainly we understand the concerns of people who are worrying about having to travel further for an inpatient bed should they need it. And we're thinking very carefully about the situations in which people may have to travel further and how we can mitigate that. But in my mind, there's no question that we can substantially improve on the offer of inpatient mental health care by designing a new hospital and redeveloping the Calmwood Court site.
Thank you. Councillor Moore?
Yeah, just obviously this is going forward a bit, but obviously if this goes ahead, it's going to be 2 years worth of construction. How much disruption of service is that going to give to? Obviously, you're probably still working on some of the finer details of that as we go through those, because I appreciate it's a draft report. But how serious do we see that patients already at the Luton Centre? How is their care going to be disrupted by the building construction of the new hospital?
So, yeah, you're absolutely correct. We are sort of still at the beginning of what is quite a big process. We would estimate the planning to take in the region of a year and the construction to take in the region of 2 years, and that's with a fair wind. In terms of the phasing, we would anticipate that the construction at the new site at the Bedford Centre for Mental Health would take place first, and then we would decant people into the new site, and that then we would do the work at the Luton Centre for Mental Health when that's complete, if that makes sense. So that we would be aiming to really make sure that we disrupt the inpatient care of people at the Luton Centre for Mental Health as little as possible.
Thank you. You mentioned the £70 million. Is that definite and committed? And
so it is our estimate of the costs following on from some initial feasibility work through our estates teams and through a team of architects. What we are just in the process of doing is formally instructing a design team who will start to take us through the sort of formal Royal Institute for British Architects design process. And so we anticipate that over the next 3 months, or 3 months after we've appointed the design team, we will get to a much sharper estimate of what the actual costs will be taking into account land conditions. You may know that our proposal is to build on the site of Shire's House at Bedford Health Village, which is a building that was experienced a fire a couple of years ago. So we need to get our architects and our surveyors instructed and on site to take a look at all of that and work through what we think the actual final costs will be. So we anticipate having that over the next 3 months or so. Like I say, that's our best estimate, and we, the Trust, are committed to covering those costs.
Question about the public consultation exercise. So going over, I think you say it's the autumn period, you'll be consulting with the public in Bedford and in Luton. How is that going to work? Is that are you going to do an ongoing evaluation of the responses to that, and how will that feed back into the plans?
So we're very mindful of the fact that at this stage we are undertaking engagement rather than formal public consultation, because in order to move to formal public consultation, you as a committee alongside the Bedford Borough and Central Bedfordshire Scrutiny committees would need to be satisfied that our pre-consultation business case was sufficiently robust. At this stage, it's a high-level set of proposals that we just want to test. Do these sound and feel like the right set of proposals for us to work up more fully into the pre-consultation business case? So we'd be anticipating over a period of 6 weeks from publication, we hope early in July, as I say, to kind of undertake a period of engagement, and we will be doing that through structured processes with service users and carers, our staff as a key constituency, with yourselves. We will hold some public meetings, we will have surveys available, we will publicise that all very prominently to seek views. So our communications team are currently just designing the kind of finer detail of that plan. Certainly Health Watch, for example, community voluntary sector, we really do want this to be a live and lively kind of big conversation really over the summer period. And the intention would be that we would then write up what we've heard and bring that back through to yourselves. We would aim to get that back to you in the autumn, so that you can see systematically what people have told us and understand what the implications are for the plans that we've laid down.
Thank you. Does anyone have anything else? Okay. Yeah, just one comment. I think you talked about the capacity and maintaining capacity, increasing capacity. I think it's also important that you're talking about, there was the user comments about maintaining dignity and privacy. That's quite important, isn't it? Very important in these plans for these new units.
I don't know whether you want to say any more on that, Dudley, but absolutely the case. I mean, one of the, the first argument that we laid down in the case for change is about the quality of the environment and the huge impact that an inpatient environment can have on people's recovery, and privacy and dignity is a really integral part of that. There are other dimensions too, but as Dr. Manns has said, kind of, the nature of the environment at Oakley Court, we're getting such strong feedback from service users and carers about the quality of the environment there. That's a major kind of thrust of the arguments we've laid down in the case for change.
So dignity goes beyond having an ensuite bathroom, but the estate at Townsend Court in particular is really challenging in that regard. So there are shared bathroom spaces, which is far from ideal.
Okay. Thank you. So I think we need to arrange a date for you to come back to us. I'm not sure when that would be best.
Chair, us as officers from the 3 local authorities, we're getting together and talk to the providers to actually organise something. And there may be also a need for a joint health scrutiny committee. But obviously we'll bring all that back once we've got some dates sorted for you.
Okay, thank you. Thank you. Item 12, update on the impact of universal credit in Luton. Nigel?
Thank you, Chairman. So, report is as presented. We've tried to do it in a format that where you've received the data before, and I've got no further updates on the data or amendments to the report, but I'm aware it's a big agenda this evening, but if I can just pull out 2 or 3 little points, small points from the report that are of interest really, and particularly in point 5 we refer to the impact of COVID-19 on employment and changes in circumstance, and the fact that it has actually accelerated what the DWP would call the natural migration to universal credit, i.e., in other words, if you're of working age and your circumstances change and you need support, you know, that is pushing you into applying for universal credit. In point 12, we update on the households of most concern, as you've received previously. But I'd now point out, certainly, that it's no longer possible in total to split out the impact of universal credit on particularly like items like collections away from the impacts, the ongoing impacts of COVID-19, the national restrictions, and how that affects the process, court opening and the like. And just finally, Chairman, if I may, obviously we've put some narrative in points 18 to 21 on the impact on rent arrears. I think it's important to note that has been quite volatile. But actually, the changes that the DWP made to APAs, particularly in the timing of them being paid, has actually reduced some of that, but that's made that less volatile than it was previously. And the housing team have reported to us that that's improved the situation for them going forward. So, obviously, the report is quite far-reaching and, as I say, it's quite statistical, but happy to take any questions if I can, or certainly we can report back in the usual manner if we need to on further details. Thank you.
The question is to do with being in arrears and evictions. How are we going to deal with that? Because, as you know, there's going to be post-pandemic, or as we come out of lockdown, there's going to be a lot of unemployment, and people are going to be suffering because their income levels are going to drop. Are we going to make sure that we are not beginning to see people on the streets because we have evicted them from their homes? How are we doing to stop that from happening? And to be frank, I don't want to see people being evicted from their homes because they couldn't pay their rent through no fault of theirs.
Yeah, so Chairman, obviously I'm the head of revenues and benefits, and that's how, you know, a housing matter. So we probably have to ask the housing team to come back with some more detail on that one. But you will be aware that obviously the court process has been closed. You know, they've put some extra measures in on evictions, but as I'm sure the members are aware that very shortly that, you know, the matters are now changing and the courts are starting to take cases. So I'm sure housing colleagues will be able to provide some more information on their updated plans in those events.
I think it's important that they come and say what their plans are in terms of whether they're going to start evicting people or not. And we don't want to see homelessness in the town post out of lockdown has happened. And for me, we shouldn't be evicting people. We should mitigate against that, make sure we keep we do everything in our part to keep people in their homes than trying to see them on the street.
Absolutely, I agree with you. Is this the proper forum for that discussion? If it directly impinges on the health of population of Luton, then perhaps, but there might be a more appropriate forum for this.
Chair, if you wish, I could put this on the agenda when you talk about the work programme. If you want somebody to come from housing to speak to you about the very issue that Councillor Agnew is asking about.
Yes.
So we,
yes,
we can arrange that and put it on the work programme.
Okay, thank you. I've got one question. Page 73.22. Children entitled to 3 school meals cannot access them until UC is in payment. Is that? I presume it's in the report, so it must be true. But it's, since looking at the council website, it seems to contradict that children could still have free school meals if they were transitioning from, if the families were transitioning from other benefits to universal credit. Is that, have I got that wrong?
So I think as 22 is as correct, and obviously has been quite an increase in school meals, free school meals take up. I mean, we can take that back to and get some technical guidance on that, and so I can't help further, I'm afraid.
Yes, please. I think that's quite. I mean, do we know if this is happening, whether children are not accessing free school meals because they're in transition?
I think I can report, because obviously we do support that actually the take up of free school meals has been quite strong, and we've got most of the schools sort of signed up through the Luton scheme. So I say that I think this is a point that was previously reported to the group actually. So so we can check whether that is still the case. So, and we'll come back to you.
Yeah, please.
Thank you.
Thank you.
Chair, do you want to come back through email or to the next time that Nigel reports on an update for you?
That's a good question. I think if you could find out the information as quickly as possible and let us know. Yeah, that'd be great. Thank you. Thanks, Bert.
So just further to that point, I was just wondering the way it was written, that point 22, whether that might actually be people who aren't on housing benefit but are then going to universal credit, and that's the difference. I mean, it's something for you to go away and possibly check. It's just the way it says until universal credit is in payment. Obviously, if they are moving from housing benefit to universal credit, they would be still in receiving a payment housing benefit until they moved over. So it might be something for you to go away and check, because the way that's written to me suggests that's people going from not on benefits to taking universal credit, and that's where they're not getting the school meals. But it's something for you to possibly check if that is the case.
Thank you, Councillor. Yeah, we'll check. I believe it might be when they access the gateway. So I think you, Councillor, might be correct.
Thank you. Any more questions? Oh. Thank you. I think item 13, the draft work programme.
Chair, this is usually on for members to review, and obviously to we can add everything that you agreed that should come back to the committee. From my notes, I should do that. But if members got anything else that they wish to make changes to or add to the work programme, this is the time to bring it up. I mean, some of the items are obviously recurring standing items that will come back to you anyway.
Councillor Hagbley?
I was thinking about the forward plan. Is there anything we need to be aware of so that if we can bring them here before it goes to executive, is there something we need to know?
In the forward plan?
Yeah.
So again, that is on the, as an appendix on there for you. I wasn't aware of any specific.
Okay.
But obviously it's there. If you think that there's something of interest, then this is the time to bring it up.
Okay.
And if it is, usually if we pick it up early, it goes up to the senior officers management team, and then that's obviously processed through the various stages with scrutiny at the first hurdle or first step.
We have the two reports, the dental reports coming up is that in September, the JSNA, the dental needs assessment and the updates to provision of NHS dental services in Luton.
Yeah.
So that will be in September.
Chair, as you can see from the work programme, that some of the meetings are quite heavy in terms of the number of items, which the previous chair tried to work its way downwards, but I think we haven't been successful in doing that so far. So it may be that, you know, if you can have a look at it, and we'll speak again outside the meeting, Chair, and see where, you know, the items could actually be programmed a bit more fairly across all the meetings.
Yep, it's a good idea. Yep. Okay. Okay, I think that concludes the business for this evening. Thank you, everyone. Thank you for the officers for their reports, all their hard work.